what I wanted to do with the first part of this is just kind of give you a very like high level overview of kind of how we got to today. What is TAVR? Why are we doing it? Who are we doing it to? And maybe a little bit more details about the procedure in the OR. And then I think after that, we're going to get into some of the finer details with Julie about the nursing care for these patients and sort of expectations and complications post-procedure. So a little bit of background. So aortic stenosis is the condition that we're treating when we treat with TAVR. It's a progressive disease, and for patients who are symptomatic, valve replacement, whether it's surgical or transcatheter, actually can improve mortality and relieve symptoms. And in the past, there were a lot of patients who were untreated because of comorbidities. And right now, TAVR is indicated for patients who are either inoperable because of some surgical reason, like a calcific porcelain aorta or bad cirrhosis. But it's also indicated for high-risk patients and even intermediate-risk patients. And I'll talk a little bit about how we distinguish those in a second. So the condition of calcific aortic stenosis, I'm not sure if you guys have ever actually seen a picture of it, but this is basically what it looks like, looking down on the aortic valve, the three leaflets of the aortic valve, and there's calcium that gets deposited on the aortic side of the valve. And so instead of opening nice and wide, because the leaflets are very thin and pliable, as the leaflets become more calcified, they don't open as wide. And it's estimated that a third of the population, the elderly population in the United States, actually have some evidence of calcification of their valve, and also estimated that 2% of people over 60 years old will require some kind of intervention, whether it's surgical or transcatheter, on their valve at some point in their lifetime. And unfortunately, even though we've tried to look at different pharmacotherapies to try to reduce the progression of aortic stenosis, there really is none. So it's really a mechanical problem with a mechanical solution. Risk factors for developing aortic stenosis are kind of similar to those that we see for coronary disease. So older age, male gender, diabetes, tobacco use, high cholesterol, and hypertension can contribute to the calcium deposition on the valve. And even if you looked at them under a microscope, see similar sort of histopathology that you see looking at coronary plaques. So there's been several, different iterations of the guidelines that help us distinguish between mild, moderate, and severe aortic stenosis. This is a slightly older version, but I actually think it's a little bit easier to understand. The current version has got so many levels of detail that may be sort of too granular for this talk specifically, but in general, we look at patients who have a valve area of less than 1 centimeter squared, or a pressure gradient across their valve of greater than 40, or a velocity of blood coming out of their valve at greater than 4. These are all echo parameters typically, although we sometimes look at these things in the cath lab as well. So those are kind of how we classify patients with severe aortic stenosis. And there's a fair amount of time where calcium is being deposited on the valve. Patient may have either mild or moderate narrowing of the valve, where you don't really see any symptoms. But there's this inflection point where the valve becomes severely narrowed and patients start to develop symptoms, and we see a dramatic drop-off in the survival of patients if nothing is done. And so the typical symptoms that we look for in these patients are symptoms like angina, dyspnea, or even syncope. And those symptoms, as well as the severity of aortic stenosis on the echo, are sort of the two key findings that we use to decide, hey, now it's time to intervene on your valve. If we don't intervene, believe it or not, like the mortality for aortic stenosis is worse than some cancers. If unoperated, 50% of patients may be dead at 2 years. So that's a pretty significant statistic there. And if you really compare other kind of conditions that maybe we think of as being more ominous or having a worse survival, like say ovarian cancer, lung cancer, we actually see a similar very low survival at 5 years with severe aortic stenosis. So it's a pretty significant problem for our patients. Luckily, for many decades, we've known that aortic valve replacement surgically improves survival. So if you look at this graph, the yellow curve are patients who have had their aortic valve replaced, compared to the blue curve here are patients that are unoperated. And that blue curve really plummets very early on, indicating those patients are dying at a much greater rate than the patients who are undergoing valve replacement. The problem was, and happily this was kind of more of a historical problem than what we see now, but the problem and what led to transcatheter aortic valve replacement was that there are a lot of people who had severe AS and had symptoms that were not getting an operation. And there were estimates from multiple different studies in the United States and in Europe that somewhere on the average of like 40% of people that had those criteria were not having an operation. I mean, if you think of that in the context of what the survival statistics are for patients like this, that's a huge number of people who are maybe dying when, without having therapy. So that was kind of what led to the development of transcatheter aortic valve replacement. I'll talk about that a little bit more in a second. When we look at our patients now, we try to estimate the sort of risk of having a surgical operation. I talked about transcatheter valve replacement is an option for people who are inoperable, high risk, or intermediate risk, and how we're kind of making that calculation before they get to the OR are using two sort of estimates of risk. The most commonly used one here in the United States is the Society of Thoracic Surgeons calculator. It's basically this huge database that after every kind of cardiac surgery, data is entered, and then they sort of have developed an algorithm that looks at patient characteristics and comorbidities that will predict negative outcomes. Negative outcomes like mortality, morbidity, some things like prolonged ventilator, the risk of developing renal failure, et cetera. But it's really using that tool. We enter patient data, for example, when we see them in the clinic, and estimate, what is their level of risk. So you may see that in the chart, when you're taking care of these patients. I just kind of wanted to elaborate a little bit further about what sort of that risk estimator is. So because of this huge number of people that were unoperated, and because of the perceived high risk of those patients to have traditional surgery, that was sort of the idea behind a transcatheter valve therapy. In the 1980s and in the early 1990s, they were using balloon aortic valvuloplasty, just like we would do in the coronaries, where you just take a balloon, stretch the valve open, deflate the balloon, but not implant a new valve. The problem is that the complications were relatively high, and the improvement in valve area was not long lasting. It was only about 6 months to 12 months, and then you were right back where you started. And so that led to the idea of, hey, can we put a valve in rather than through a median sternotomy, but with a catheter? And so the first person to do this was Dr. Cribier in 2001 in France. And this is kind of a crude picture of what this looked like. They basically manufactured this, in someone's garage with a, stent frame, and sewed some tissue together in the shape of a valve. And luckily the first person that received this valve was like a 50-year-old gentleman. He had lots of comorbidities, bad peripheral vascular disease, bad cirrhosis. But he lived for several months until he ultimately died, not of aortic stenosis or any cardiac problem, but one of his other conditions. So that was sort of proof that this concept was going to work. And in the ensuing years, we really saw more details of how this procedure would work well. So the benefits of TAVR, an improved recovery. And I think many of you may have seen our patients on the floor. They're able to get out of the hospital in like 2 to 3 days compared to maybe a week after traditional surgery. We also don't require the cardiac bypass machine, which also can be pretty tough on some of our elderly patients. The vast majority of the time, we can do this completely percutaneous. So what that means is over 95% of our patients, and this is true for UT Southwestern specifically too, over 95%, this is performed just through a transfemoral access. So similar to what we would do for a cardiac cath, though slightly larger sheath that's used. In those remaining 5% of patients, other access sites can be used, such as transaortic. So that's through sort of a small incision through the second and third rib on the sort of right upper chest. We can also use a transapical approach, which is sort of on the left-hand side of the patient, usually around the fifth intercostal space, where we directly puncture the apex of the left ventricle. And also there's sort of the axillary approach on the sort of left side of the chest, almost kind of near where you'd put a pacemaker in. We sometimes use that approach. But luckily, the need to do that is really not very great anymore. So I'll tell you just a little bit about the two current valves that we're using. The Edwards Sapien S3 valve basically has two components. There's a metal stent. It's made of cobalt chromium, just like our coronary artery stents, just substantially bigger. The valve itself is made out of bovine pericardium. So they basically take the pericardium of the cow, they clean it, process it, and then press it out almost like Christmas cookies. It's actually really fascinating to watch this happen. They press out little shapes like Christmas cookies and then sew the valve in the correct shape inside the stent frame. And then around the bottom edge here of the valve, you can see this little skirt that basically helps seal the valve in the annulus of the patient. And this is balloon expandable, so it goes in compressed. It's about the size of your pinky finger when it's going in through the transfemoral approach. And then once we get it in place, we basically inflate a balloon and then deflate the balloon, which expands the stent. And then once the balloon is deflated, the valve starts to work. So it's kind of a lot like a coronary stent procedure, if you've ever seen that, just on a much greater scale. So for example, a coronary stent, oftentimes we're talking about 3 millimeters in diameter. These are usually 26 millimeters in diameter, would be an average. The other valve that we use is the core valve Evolute. There's an Evolute R and an Evolute Pro. This is a really slightly different type of valve. It's much taller. So the other one is about 14 millimeters tall. This is about 5.5 centimeters tall. So it's a little bit different shape. It also has a stent component. It's made out of nitinol. So this is a self-expanding stent. It's basically a metal that has memory to it. So you can compress it to put it into the body. But once you sort of expose it to blood, it heats up. It springs back into the shape that you see here. And that's kind of how you deploy it. You don't do it with a balloon like we do the other portion. Similar to the other valve, there is tissue within the stent frame. This is pig pericardium rather than cow pericardium, but similarly, it's pressed out from a flat portion of the pericardium and then sewn into the valve shape. The difference between the R and the Pro, if you're curious, the Pro has the same kind of skirt as the other one does to help seal the valve in the annulus. So let's just talk very briefly about some of the data, again, just so you're kind of aware of this. It's not meant to be all-encompassing, but when the randomized studies were first performed in the late 2000s, so the first study that really we got data on is called the Partner Trial. This one was using the balloon expandable stent system. And in patients that were inoperable, so those with extraordinarily high risk for traditional surgery, there was a 20% improvement in survival. That's absolute risk, or that's an absolute improvement in survival. And basically 1 out of every 4 patients that was treated had a benefit of living to a year compared to those who were untreated. So it's in the world of cardiology, this is like a profound improvement in the outcomes of these patients. There's almost no medicines that we give or any other procedures that have this kind of like huge effect on the patient population. What we saw in addition to that is not just that patients were living longer, but they also had an improvement in their heart failure symptoms and other symptoms. And so like for this graph, for example, if you compare these bars, so the ones closest to me, that pair, these are NYHA class or severity of heart failure before the patient was treated. The blue bars and the purple bars mean they have class 3 or class 4 heart failure, really sick population. Then if you look at 1 year of the non-red portion of the bar graph, so these are the surviving patients, the vast majority have yellow or green, which is class 1 or class 2 heart failure, so a substantial improvement. And the majority of people who survived had very low level symptoms. So also very encouraging to know that this was not just an interesting concept, but something that actually saved lives and helped people feel better. The other sort of branch of this landmark study was looking at what about TAVR compared to surgical valve replacement? It works pretty well compared to just doing nothing and watching the patients die, but how does it compare to traditional surgery? And in this study and in multiple other studies, it basically worked pretty darn well comparatively. So in this study, we called this, the TAVR was quote unquote non-inferior to surgery. In subsequent studies, it's actually been superior to surgery. Don't tell Dr. Jessen I said that. At least in short-term data. So we can be rest assured that in the appropriate patient population, we're not sort of skimping on the treatment. We're actually giving it equal, if not better, in some instances, therapy for these patients. And again, we kind of looked at patients who were either treated with TAVR versus those treated with surgery, what happened to their heart failure symptoms. We had a similar improvement of heart failure seen in the TAVR population as we had with the surgical population. So, as somebody who's recommending this procedure, it's reassuring to know that not only are patients going to live longer, but they're going to feel better. So let me now start to give you a little bit more insight on how we evaluate the patients, like what happens before they actually come to the OR. So there's sort of a series of steps. The patient, number one, is identified as having severe symptomatic aortic stenosis, usually by an outpatient echo. Patient is seen by a cardiologist, and then they refer them to our valve clinic. In the clinic, they're evaluated by an interventional cardiologist like myself or one of my partners, and then typically evaluated by 2 cardiac surgeons until the decision is made, yeah, maybe you're better as a TAVR candidate versus surgery. That may change in the coming year or so as Medicare sort of changes its policies for this procedure, but at least that's the way that it stands now. So typically you'll see either my name or Dr. Kumbani's name in the chart, and most often our 2 surgeons working with us right now are Dr. Jessen and Dr. Huffman. We review the echocardiogram looking at the severity of aortic stenosis. We also perform a very detailed CAT scan. I'll show you some of the pictures of that. That really lets us determine non-invasively like what size valve does this person need, because a very petite person would need a much smaller valve than someone who's larger. And since we don't have the luxury of being able to hand size valves like they do during an open procedure, the CT scan is really crucial for us to really tailor the appropriate valve for the patient. They all also undergo cardiac cath, both a right heart cath and a coronary angiogram. Sometimes they get a PCI beforehand. And it's really not until all that stuff is completed that then we make the final decision for or against TAVR, and they're scheduled for the procedure. So this is kind of what we look at in the echo. This is a still frame. What you're looking at kind of in the center, all those little blobs are calcium on the aortic valve. And we do a number of measurements looking at the widths of the sort of aortic valve complex here. That kind of gives us our first clue of like what size valve might we be looking at. We look at other anatomy, such as, does the aortic valve have the typical 3 leaflets? Is it a bicuspid valve with only 2 leaflets? That may impact our procedure. So this is kind of one of the examples of what the CT scan images look like. So this is a scan looking at the exact aortic annulus. This is done in a really precise way. And then we take an outline of the annulus, take a minimum and maximum diameter of the annulus, and then an area, and kind of use those kind of measurements to help fit the valve to the right size prosthesis. The other component of the CT scan that's really crucial is looking at the peripheral vasculature. So in the same study, during the same scan, we basically get image data from the aortic valve all the way down to sort of mid-thigh. And that lets us see whether or not the femorals and the iliacs are adequate in size to be able to deliver the system. So when we first started doing this, I used to say that the delivery system was about the size of my thumb. It was huge. And now, several iterations of technology later, it's about the size of my pinky finger. So most people's arteries can accommodate that, but you don't want to take a risk. You need to know for sure to make sure that you don't have a vascular complication. As I mentioned, the preferred approach is transfemoral. Right now, the sheaths are either 14 or occasionally 16 French in size. So that's the equivalent of what we use for the Impella device that goes in the OR to kind of give you a reference. As I said, if the patient's access is not adequate, we can use either a transapical approach, this middle figure here, where we literally stick a needle in through the apex of the heart through an incision here on the left side of the chest, or transaortic from the right side of the chest, poking down into the ascending aorta just a little bit proximal to the innominate artery. So, play the video. Let me tell you a little bit about the procedure. So most of the time our patients will undergo general anesthesia, although there is some interest in doing this with moderate sedation, believe it or not, as the device has gotten smaller and we've sort of made this a less complicated procedure. Most of the time, we have access in both groins. One side will have the larger sheath. The other side has a pigtail catheter, which you can see here sitting in the aortic root. That allows us to see where we're going, lets us do an aortogram to provide us a sense of where we're going to place the valve. We also put in a temporary pacemaker from the leg that allows us to pace the heart rapidly, which assists in us having stability of the valve as we're deploying it. And so you can see those things here. So this kind of catheter that's coming up from the bottom left corner, that's the temporary venous pacemaker that's sitting in the right ventricle. The pigtail catheter there is sitting in one of the sinuses of Valsalva. And then we have a pretty hefty sized wire that's going all the way up around the aorta and then kind of curled into the left ventricle. This is an example of a balloon valvuloplasty. So in maybe about 50% of cases, the valve is really, really tight. And before you can deliver the new valve, you have to stretch the old one out to be able to accommodate the delivery of the system. So we wind up pacing the heart. This is kind of an example of it here below in the right corner, where we pace the heart really fast at about 180 beats per minute. And if you look at the lower line on that tracing, that's sort of the A line there. By pacing the heart really fast, the blood pressure drops usually to below 50. Your pulse pressure is usually less than 10. You're pacing it so fast it doesn't even, the heart can't really pump anything. So the balloon is stabilized and you can inflate it and deflate without things moving around too much. So that's kind of what the valvuloplasty looks like. So now this is actually our very first TAVR that we did here at UT Southwestern in 2013. So again, we're pacing the heart really fast. We take a picture with the pigtail to confirm we're in the right spot. And then once we're in the right spot, we inflate the balloon, which expands the stent frame. And what you can't see, obviously, is the tissue within the frame. But you'll just have to believe me that it starts working as soon as you deflate the balloon. So that's basically what's involved. A lot of times these patients will have transesophageal echo that assists with placement, looking for post-implant complications. And then our anesthesia colleagues will typically put in monitoring lines from the neck. They may or may not have a temporary pacemaker wire from the neck after the procedure. But I just wanted to at least show you guys what it looked like so you have maybe some of what I'm talking about has a little bit more of a concrete sort of anchor here. The other kind of group of people that we treat with TAVR are patients who are considered frail. So just because you're 80 years old doesn't mean you're frail. There's a lot of really vibrant, active 80-year-olds, but there are some that are, even though they don't have a lot of comorbidities like cirrhosis or pulmonary hypertension, they may not be great candidates for surgery because they just, are bed-bound or wheelchair-bound, et cetera. And so one of the other things you might see in the chart are measurements of their 5-meter walk or 5-meter gait speed. So generally someone who is non-frail can walk 5 meters in less than 6 seconds. I'm pretty sure everyone in this room could probably do it in 3 seconds or less. If you're over 6 seconds, that means that you're slow, you may be frail, you may have a hard time recovering from traditional surgery. Think of all of our patients with walkers. If you're walking like this and this is how you move to get around, now you get a sternotomy. It's really hard to use your walker when you've had a sternotomy. So maybe you're a better candidate to have TAVR rather than surgery. Let's talk a little bit about complications. Happily, these don't happen as often as they did when the procedure was sort of in its infancy. But here are some of the key complications that we are meticulous in trying to avoid. So number one is paravalvular leak. So because we don't go in and cut the old valve out, there's a lot of that calcification there in the annulus that remains when we put the new valve in. It's helpful because number one, it helps keep the new valve in place. It actually acts as a good anchor. The downside is that some of that calcium, especially if it's sort of irregularly located, can allow little cracks and crevices for blood to leak through between the patient's original valve and through the prosthesis. Used to happen more often, but now with new technology, it's less common. And I'll talk about that here in just a second. Another complication that is feared is a vascular access complication. So back in the day when the delivery systems were the size of my thumb, And we didn't do as good job of looking to see are the iliacs and the femorals adequate size to deliver this. There are literally cases of people putting the sheath in and then they couldn't take it out. They would go to take it out and the iliac artery would be on the delivery system, which obviously that's not good. Now the risk of vascular complications is much lower, about like 10% or less of a risk of vascular complication, anywhere from just a hematoma to something requiring intervention, like either a angioplasty or some minor vascular procedure. Stroke was also a very feared complication. There's a much higher risk of stroke, about 8% in some of the earlier studies. Now that risk is down to 2%. You can imagine you've got this very calcified valve. You now either inflated a balloon or put a new valve in there. You're disrupting that calcium. Does some of it go up to the brain and cause a stroke from embolism? That's sort of the etiology. And finally, we look at the possibility of heart block and need for a permanent pacemaker. So the risk of that happening now is about 10 to 15% of patients, and it's usually those who have some underlying conduction abnormalities going into the procedure. So people with atrial fibrillation are at higher risk, people that have a pre-existing right bundle branch block or left bundle branch block. And it doesn't happen on everyone, but it can happen. So why do we care about some of these complications? So looking specifically at paravalvular leak, if a patient has a moderate or severe level of leak, and it's usually we usually sort of grade this looking at TEE or angiography in the procedure. If your leak is greater, your survival is worse. So ideally, patients will come out of the OR with either none or mild leak. We try pretty hard to eliminate that. Why do we care about vascular complications? Aside from just wanting to avoid complications, those who have vascular complications are at higher risk of dying. Now, this is a little bit older data from some of the earlier studies back when the sheath sizes were larger, but the same, idea is still true today. Cerebrovascular events, most of the time these happen within the first 24 hours. Luckily, I think we've only had 2, knock on wood, in our almost 300 case experience here. And we've known it usually within the first day or so. It's rare to see this happen sort of down the road. So what about anticoagulation? Right now, during the procedure itself, we give them heparin, and we shoot for an ACT of 250. It's kind of similar to what we use for our coronary stents. After the procedure, the vast majority of the time, we reverse them with protamine, like we would for cardiac surgery. Post-op, when they hit the floor, typically they're given aspirin, 81 milligrams, sort of indefinitely, and then clopidogrel or Plavix for about 6 months. That is assuming they don't have another indication for Plavix, such as a recent coronary stent. If patients have conditions like atrial fibrillation and they have an indication for full anticoagulation with warfarin, then we skip the Plavix and just treat them with warfarin and aspirin. There's even some patients who, like cirrhotic patients, for example, with low platelet count, that we may even skip the aspirin and kind of decrease the amount of medications further. But this is generally what they're being managed with post-operatively. So I hope that with this little brief intro here, hopefully you are now more aware that aortic stenosis is sort of a progressive and lethal disease if it's gone untreated. But happily, after valve replacement, survival is improved and symptoms are also improved. And transcatheter valve replacement since 2011 has been an approved therapy for treatment of patients with severe symptomatic aortic stenosis who are either intermediate risk, high risk, or inoperable. And with that, I would love to answer any questions that you guys have. Yes?
How do you choose between the 3 different valve options?
So generally, there's some kind of anatomic issue that you see on the CT or on the echo, say they have a bicuspid valve or a tricuspid valve, or say there's a distribution of calcium on the CT in one place or another, that in general about 30% of patients are maybe better off with the balloon expandable valve, the Edwards valve. About 30% may be better off with the self-expanding valve made by Medtronic, and then the rest is kind of a toss-up. And I think that us, like many institutions, we're probably a little bit more comfortable with one valve versus the other. And so it may be that if you're kind of a toss-up, you use the valve that you're more comfortable with. But yeah, it's usually based on the CT. Occasionally, it's based on where you would get access. So, for example, there's a patient that we have evaluated that they'll probably get a TAVR sometime in June. And because of her large body habitus and how much soft tissue she has by her femorals, we're going to wind up going axillary on her. So really the only valve that is convenient to use from an axillary approach is the self-expanding valve. So that's what she's going to get. So, but yeah, yes.
With the different insertion areas, is their recovery time shorter, longer, the same?
Yeah. So the recovery, yeah, that's a good question. So the recovery time for trans-aortic or trans-apical is usually about 1 or 2 days longer. They will come out of the OR with a small drain, not the large size chest tube for a typical cardiac surgery. It's usually just a smaller drain. And so that we kind of keep that in until the output is lower. So that usually extends the stay a little bit. But even those, I would say, are being discharged several days before they would if they were to have a median sternotomy. Okay.
Just adding on to that. So would those patients still come to the PACU then, or would you?
No, don't worry. Yeah. Yeah. No, for right now, we're going to only look at transfemoral patients. Transfemoral patients who've had all their sheaths out of their groins. So, yeah. 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 No, but that's a good question.
With the valve, the Pro, you said it didn't have the skirt at the bottom. So how does it prevent leakage?
So the R doesn't have the skirt, but the Pro does. So, the reality is you don't have to have the skirt. It's not like the valves before the skirt was in place had just wide open leak, because the valve tissue extends from the lower third of the valve. And so that stented area that has tissue on it acts as a seal. But by giving you a skirt, it gives you just another layer of seal besides just the valve tissue. I think that it helps sometimes, but I don't think it was like this huge, wow, having the skirt on the valve has really changed our amount of leak. Really, the leak elimination is based primarily on getting the right size valve in there. Yeah.
Since it's partially stainless steel and partially tissue, is there a click that you'll hear or anything related to it being kind of like a half mechanical, half non?
No. So these, from an exam standpoint, will sound just like a bioprosthetic valve. Most of the bioprosthetic valves that are surgically implanted have like a plastic sewing ring and these posts that act as structures to help support the tissue that's the actual valve itself. So think of the stent frame on these valves as similar to the sewing ring and those posts on a typical tissue valve. You won't hear a click like a mechanical valve. They don't need to be anticoagulated like a mechanical valve does. So it'll be more along those lines. Yeah. Any other questions?